asked to come talk about airway management, and the way I did it, I divided up into kind of two different parts, pre-op and post-op management, since that's pretty much where you guys will all be. Pre-op management, those of you who do sedation in endo, in pain, or wherever, we're helping us with sedation in PACU and pre-op when we're doing blocks. These are kind of things that we all need to be looking at and preparing for. So the airway may be real easy to identify. This is going to be real hard, or sometimes it may be less obvious that you're going to have troubles maintaining an airway. Go ahead. Like such as this, you see somebody like that, a big old goiter like that come in, like that's going to be a little difficult to manage that airway. I want to make sure I'm well prepared or have assistance nearby to help me manage this airway. Another difficult airway is this young girl, but she's 10. She's got a big chondrosarcoma in her face, and the difficulty isn't the airway itself, but the visualization of the airway in this case, because you can't see the tongue, you can't see the axis from the oropharynx into the larynx. And some are less easy to identify, such as this guy here. Beware the beard. Sometimes people have beards because they like beards, sometimes they have it because it masks the look of that jaw. You see this guy has no jaw, and somebody with no jaw or have that big overbite kind of can make a much more difficult intubation. So people with beards are always, you always have to be leery of those type of people. So when we go to assess an airway, we're looking at these 4 different things. Look at the Mallampati score. You guys probably heard us talk about that. And environmental distance, how wide can they open their mouth? I had a perfect example of that one today. And then the atlanto-occipital joint extension. So Mallampati, grade 1 through 4. What you look at is the soft palate, uvula, and then tonsils, and then the hard palate. So as you can see, this one here, all are visible right here. You have the tonsils, you have the uvula, soft palate, and the hard palate. In grade 2, you lose the tonsillar pillars. Grade 3, you lose most of the uvula, you just have the soft palate. And in grade 4, you have just the hard palate. So, to assess a Mallampati score, what you want to do is have the patient open their mouth as wide as they can and stick their tongue out. They don't need to say anything; just have them stick their tongue out as far as they can, and you will look in there, see what you see, and go from there. So the reason we do this is because following sedation, obstruction can occur because the tongue may fall back and into the posterior pharynx and obstruct everything. And 50% of all grade 3 airways are difficult intubations. And if they're a grade 4 airway, that goes up a little bit from there. But just because they have a bad Mallampati 3 or 4 does not always mean it's a difficult intubation. So, but it's just one of many things you got to look at to hopefully give you an idea of where you're headed. Some of you have seen this guy. This is what you don't want to see when you ask somebody to do a Mallampati. Can you click on the video there?
Okay, Andy.
Yeah, that's not what you want to see when you have some try to do a Mallampati score. That guy had an AV malformation of his tongue that we fixed in Ethiopia last month. But yeah, so sometimes they can be a little challenging. That's why you want to assess these people. Don't just look at them. You can't just look at them from afar. You got to go up and talk to them and actually assess them. And hopefully you never find anything like that. Next thing you want to look at is thyromental distance. So here we're going to measure from the cricoid cartilage. If you all feel in your neck, you can kind of feel your Adam's apple, and feel it from that spot to the tip of your chin. And if the thyromental distance is less than 3 finger widths, may make the laryngeal access too acute to intubate easily. So if they got when they have the very short chin, and that again makes that thyromental distance a lot shorter and could make it much more difficult intubation. And the reason we assess this is because it helps give us an idea of how much room you have to displace the tongue when we're intubating. If there's not a lot of room back in the back of the throat and that posterior oropharynx, there's not a lot of room to move that tongue and get a good visualization. So mouth opening, we want to see the inner incisor gap. So can the patient put like 3 fingers in their mouth like this? All right, the lady I had today, 2 fingers would have been tough to get into her mouth. So you have them open up their mouth, and sometimes people will open real wide and you'll see everything. Other times it's like they just barely open, and then you know you're going to have troubles. So less than 3 centimeters, so about 3 finger widths, is going to be could possibly be a difficult intubation. If they're less than 2 centimeters, they could even have trouble getting an LMA in the back of their throat. That becomes very difficult. Sometimes people have large incisors that cause this to be a problem. Sometimes it's just a plain small mouth. Sometimes it's TMJ. So things when you're starting to do your airway assessment, just kind of ask, or if they bring things up, they say TMJ. That's something kind of send a little bell off in the back of your head that, hey, we may have troubles. So again, when they're small like that, it just makes visualization much more difficult. And the last part here is the atlanto-occipital joint extension. So we want to have somebody go ahead and tilt their head back as far as they can. Just have to tilt it straight back. And what that kind of helps us tell is, can we align those axes for intubation? Because from the oral airway down to the larynx and everything, can they tilt their head back far enough to do that? So head extension less than 35 degrees is a predictor of airway difficulty, because especially in big patients, if you've seen us ramp them up, we'll put a bunch of blankets underneath their shoulders and stuff in their head, kind of get them in a sniffing position. And lots of reasons that they may not be able to tilt their head back, whether they've had surgery on their neck or things like that, could cause a lot of problems. Sometimes there's kyphosis. You see the little old people that are bent over like this that can't, you take their pillow away and their head just hangs there. That's makes it much more difficult intubation and managing their airway. A lot of first things we do when we have somebody whose airway obstructs is what do you do if you have somebody obstruct their airway? What do you do?
Just
do a little jaw thrust or a chin lift, and the chin lift isn't going to do a whole lot when they don't move at all. So yeah, so the jaw thrust in those cases definitely helps a lot more. That's kind of just a quick overview on the pre-op stuff. So we'll move into like post-op complications. This is what mostly this is here. So we got 6 different things that I've kind of identified that we may see around here. So the first one is obstruction. Obstruction could be a couple different things. As you can see, this here is vocal cord edema. You see on the left normal cords, and the right is some edematous cords. Why? Sometimes just a woman having a natural vaginal delivery and they'll look like this for weeks after birth because of that pushing and all the pressure they put trying to push. Their vocal cords will be very swollen and making it actually difficult intubation after that. So other things, we have blood, saliva secretions. Anytime we work around the head or neck doing surgeries, we always have an increased risk for this. May not always be visible. Sometimes they're not. You may not have a lot of exterior swelling, but you can get interior swelling, whether it had been a difficult intubation in the past. Multiple attempts at intubation can cause vocal cord edema. Anytime we're doing any of these microlaryngoscopy type stuff, can definitely add risk to that. Swelling, we talked about a little already, but multiple intubations. Airway compromise maybe from surrounding structures. We had a case just this last fall where they did a plastics case, and the swelling and everything from that plastics case started to cause the patient to become short of breath and had a very difficult time re-intubating the patient afterwards. And as I mentioned, postpartum airway edema may be significant, and that's for usually about a month afterwards that they may have a significant amount of swelling. So when we do these postpartum tubules, things like that, that's one of the things you got to kind of be careful of. So, airway foreign bodies, lots of different foreign bodies out there. I mean, whether it be us from putting surgical sponges in, I think even next door we had the dental case where they put a throat pack in after when they start. They forgot to pull the throat pack out. Somehow it didn't come out with the tube. And so that, things like that. Gum. I don't know how many times you see pictures on different websites, like for CRNA websites and stuff, that they're pulling the LMA out and a big wad of gum is coming with it. I mean, just as easily that gum could have been pushed out in the airway and it caused a lot of trouble. Jewelry, get the jewelry out, especially if it's in tongue or lip and or that kind of stuff. That stuff needs to come out. The risk of that being dislodged and going down into the airway is fairly significant. So has anybody ever taken tongue rings out? You guys ever pulled those out? So usually a lot of them are just little. You have to get like a pair of hemostats or something and unscrew the bar, especially the little barbell ones. Unscrew the one end off and pray you don't drop it while you're doing that. It stinks. So you're much better off having the patient awake and making them take it out. So get it out before they go back to the OR, before you start sleeping them, because it's no fun afterwards. Anybody else see any other type of foreign bodies in the airway? Okay. So you have something like that happen. First of all, don't panic. When somebody starts panicking, it just kind of goes throughout the whole team that's there. So just kind of keep your head, and if you're planning ahead, like we talked about, assessment, doing your assessment ahead of time, you kind of know that there may be a problem. Knowing that hey, they just had some type of head or neck surgery, that this could be an issue, and making sure your equipment's there, knowing where your equipment is, and hopefully going through this class will help keep things in mind so that you know where you're going to go after this. So first of all, don't panic. Next, first of all, treatment is prevention. Like I say, getting tongue rings out, make sure people don't have gum in their mouth or throat lozenges or things like that in the mouth preoperatively. Identify the obstruction. You have to be vigilant. That's why we send them to PACU for a while, is where they get that one-on-one care, and things can be notified, or things will be noticed and hopefully treated early. Have your suction available. I know with all the JACO stuff and all the other kind of stuff around here, they don't want suction set up beforehand, and it's really makes it even more difficult when you do have a problem. Notify appropriate personnel. Whether it just be another nurse that, hey, I'm really busy, dealing with pain, but can you come over here, you give the person pain medicine while I suction, or if you need more advanced help, like a CRNA or somebody like that there to help manage your airway. Or letting Dr. Pease know, it's like, or if it's his case, or Fincham or Purdom, that hey, I'm having more trouble, we're having a lot of swelling here. Maybe it needs to go beyond just CRNA, maybe it needs to be something surgical that's taken care of. So I know that one patient, they went and took her back and they pulled out gobs of blood out of her neck. That was just helping compress all those tissues there. So difficult airway equipment availability. I'm thinking most of you have been here long enough to know where difficult airway equipment is, but we all know where the storage scope is, usually kept. Fiber optic bronchoscope, know where that's kept. Intubation LMAs, know where those are kept. Do you know, Lindsay?
I don't know if I know where those are. Are they on the cards?
No, they're up in the cupboard. Do you know where the regular LMAs
Yeah,
are?
yeah.
Up the top
Oh,
shelf
yeah.
of that cupboard. So, yep. So what else we got? Surgical Craig stuff. That's probably the other thing. And trach stuff.
Mm-hmm.
I mean,
I don't have a crush card.
There's a trade kit on each crush card.
yeah. So the trach kit in each crash card,
And you have
and you would
the
know where the
actual
surgical
insurance set.
airway stuff is, because that's it. If we can't get them intubated, that's kind of the next thing. Bougies. You guys know where the elastic bougies are?
It was on the top of your card.
There's usually one on top of every anesthesia cart. Otherwise, I think they're down in the big, tall cupboard in anesthesia. So
And I think Pain Clinic in Indo has a small airway kit.
they've got a small airway kit. You guys
Start
have
with.
LMAs and a laryngoscope in there, I think.
Yeah,
if I remember
something to
right.
start with at least.
Yeah, something to get you going, and not really a difficult airway, but just an advanced airway kit. Yeah. So next one is laryngospasm. Have you guys seen laryngospasms? No? Have you seen a laryngospasm? Okay. So what happens here is you extubate the patient, or you're just doing a MAC case, and all of a sudden you'll hear a and the patient's chest is moving, they're trying to work to breathe, but they're moving absolutely no air. And the vocal cords slammed shut is what happened there, and they're not moving any air at all. And it can be very scary. It can happen to adults or kids, and a lot of times it's due to some sort of irritation to those vocal cords, whether it be secretions, blood, or something like that gets on there, is what we usually blame it on, and they slam shut. And we'll talk about what you do after that here. But the incidence is 1% in both adults and children, where the adult word disappeared too. But and then 10% in very young with airway disease. So if you're there, I think it's like 6 months and younger, if they have reactive airway disease or something like that, and it can happen there. And we all, I mean, you guys know when you've seen it, it becomes a little bit of a pucker factor, because sometimes it takes you break it pretty easily. Sometimes it may take 30, 40 seconds, but their sap drops extremely quickly. So, next. You hear some of that inspiratory stride, you're like, and I mean, it's a squeak, and then they're done. You'll see increased respiratory effort. You'll see that chest move up and down, that paroxysmal respiratory effort with the stomach and chest, and then, like I said, oxygen desaturation pretty quickly. So, causes could be just kids with reactive airway disease, and we usually blame on secretions or something down there irritating those cords. Next. Treatment is supplemental oxygen, so if they don't have oxygen already, throw some on. And especially if it's if you suspect a laryngospasm, just go ahead and grab the ABU bag to oxygenate, because the treatment for this is usually positive pressure ventilation. You want to, every time you see their chest rise, you want to try to squeeze air in, and even when it's not, you want to continuously maintain some positive pressure there. As high as you can get, because that's what's going to pop those vocal cords open most of the time. I've not had to do it yet, but muscle relaxation, if they're not popping those cords open, is the next treatment for that. So you want to give some succinylcholine choline, whether it's IM or IV. However, get it in them, because that's going to help make them relax those cords and help them breathe. And then suction, get those, if it's secretions that's on the cords causing that the laryngospasm, you want to get rid of the irritant. So I've seen kids drop, their sats down in the 40s and their heart rate starts coming down, and then that becomes real scary. But as long as eventually you'll start moving some air, and a lot of times you have to mask them for a little while afterwards, because you continue until I quit hearing that little bit of a squeak. I'm not going to bring the patient out to the PACU most likely, because one, the PACU girls get mad at me, and two, it's a little scary for everybody. So the problem with laryngospasm, anybody know the secondary problem to laryngospasm? What you're likely to see? Negative pressure pulmonary edema can happen after a laryngospasm, because what's happening with those vocal cords are slammed shut, and then all that work they're doing is trying to expand their lungs and everything. Instead of pulling air in, what it does is it pulls water into their lungs. And I've seen a couple adults here have it, and I think I might have had a young kid, 3-year-old, that we shipped to a while back, that it was even quick laryngospasm after that one, and he ended up getting sent to Stormont because of pulmonary edema afterwards. So sometimes you want to watch them. If you know they've had a laryngospasm, they've been told it, or you see it in the PACU, you want to watch them for a little bit longer, just make sure that they're maintaining good sat and not having their lungs are clear and everything, not having any additional problems, because that's happens actually a fair amount. So. Next one is bronchospasm. So the contraction of the smooth muscle of bronchi causes narrowing, possibly obstruction of the respiratory airway. What you'll see there is you'll see more wheezing rather than inspiratory stridor. They'll be coughing and moving air, yet most of the time they can move at least a little bit of air. They'll complain of having difficulty breathing, tightness in their chest type stuff. If they're on a ventilator, you can have, they still have this happen, whereas laryngospasm, they can't spasm if you have a tube through their cords. So you'll see your peak pressures increase quite a bit on a ventilator because of the narrowing. It's harder to ventilate. Treatment of this is going to be the beta-2 agonists, like albuterol, Zopanex, those types of things. And that's those, so they're bronchodilators. IV methylprednisolone, Atrovent, and IV magnesium. The magnesium will help relax smooth airways. So those would be kind of your main treatments of that. And you may have to continuously watch them. If they're having bronchospasms, that can be a significant problem. So. Next, aspiration. As you can see on the your guys' left, it's a normal chest x-ray. On the right, it looks like somebody has aspirated. That's classic because you see on the right side is where they've aspirated at, because that's a more direct route, because the left main bronchus curves off more. Usually they'll be on that right side that they'll aspirate stuff into. So that's why we do our MPO guidelines. Hopefully we maintain those. Symptoms of this would be coughing, choking, gagging. They may even feel like they've had that reflux in the back of their throat type thing. Shortness of breath, and then just a decreased oxygen saturation that you just can't get up. Treatment of this is usually symptomatic. A lot of times now they say you don't even really need to give antibiotics or anything like that. But if it's an at-risk patient, you can go ahead and do that. May need to be admitted for observation because you can't get their SATs up, or they just need to be watched a little bit closer. Most of the time with the aspirate, in our situation, it should be just clear liquids without particulate, and shouldn't really cause any problems other than maybe just a little bit of drop, a little bit lower oxygen saturation, which easily resolve itself. So hypoventilation, little chubby guy there. Next. Could be a number of factors that cause hypoventilation. It could be sleep apnea, could be narcosis due to the pain medications that they're getting or that they've been taking at home, or who knows what they've been taking at home. We get people of all sorts these days that come in and they take a lot of different things. Could be COPD that they're coming in with, that they're having an exacerbation of. Could result in diminished oxygen saturations, and may also result in hypercarbia, which is almost as dangerous. With the hypercarbia, what that does is it increases their CO2, they become more lethargic and then ventilate even less, and then just kind of a nasty cycle right there. So sometimes their oxygen saturations may be 98%, but if their tidal volume isn't high enough and they're not breathing off that CO2, they're retaining it, and that can make that problem a lot worse. Hyperventilation can be very difficult to identify without the right monitoring. I think we're becoming more in tune to end-tidal CO2. I know pain and endo is using it now all the time. They're supposed to be. We need to get better at pre-op and PACU when we're doing procedures and stuff there, because I don't think we have the capability of pre-op, and we're stating people there, and PACU.
We have one monitor in PACU that's like rolling, and it has the module.
Okay.
If we needed it for like sedation.
Yeah. So we need to be better at that. I wish we had it on everybody, because it'd be nice to have, even on our PACU patients, just to watch. End-tidal CO2, when the patient quits breathing, have you been using it much, or are you doing much sedation?
We don't in pain, but I know they do in endo.
Yeah, when the patient quits breathing, you see it immediately. Unlike an oxygen saturation, where it's going to take 3 to 5 minutes for their oxygen to start dropping, you'll know immediately when they quit breathing with an end-tidal CO2 monitor. So our goal is to improve arterial and pulmonary oxygenation. So we want to add more oxygen to that, and we also, by either increasing the percentage or increasing the tidal volume of that patient. So treatment, like I said, increase oxygen flow. So turn up your O's. You just got to be careful in those real severe COPD patients that you don't get rid of all their respiratory drive and blow off all their CO2. Sometimes maybe be a nasal or oral airway that you need to put in. Again, you guys your staff are more than welcome to come back to the OR and hang out with us, and we can, if you want to never done it before, you can do that. You can manage airways, you can learn how to do chin lifts, jaw thrusts, all those type of things. Just come on back to the OR and, talk to one of the anesthetists back there. Most of us are more than happy to let you hang out or try to get you in the cases that, will possibly be needing those. And don't be afraid to do that. Sometimes we wait too long to actually put those in. I'm even guilty of myself in the middle of the case and getting frustrated that I can't do my charting because they would do a chin lift over here. I'm like, stick an oral airway and it'll be done. And make your life a lot easier. Narcotic or benzodiazepine reversal. We all know to reverse narcotics we use Narcan, and for benzodiazepine we use flumazenil. So, yeah. Ensure complete muscle relaxant reversal. If you're getting patients in the PACU and they're having trouble breathing, I know you guys probably all, those of you who work in PACU have seen it, but just ask the nurse, ask the anesthetist, hey, if you know they had a tube in, did you reverse them afterwards, or do they need reversal? Because sometimes they're guppy breathing, or they'll tell you, I just feel weak, and that's because of that muscle relaxant that they may still have on board. Sometimes they need CPAP or BiPAP. Are you guys using that much?
We haven't really been, but we have.
Yeah, okay. Have you guys seen it used much in endo or anything? No. But we do have the capability of doing it, especially those people who are on CPAP at home or may need it and still don't use it at home, or known sleep apnea. Need to maybe get that on. People with sleep apnea, there's two different types. You have central and obstructive sleep apnea. Obstructive sleep apnea is what I'd much rather be treating people for because it's a lot easier. You just open up that airway again and you're better. Central sleep apnea, those patients, it's in the brain. You can open up the airway and they're still not going to breathe. So you got to stimulate them in other ways. So CPAP and BiPAP will still help that because it'll help assist whatever they're already doing. Or may require invasive ventilation assistance. So they may need, if they're not breathing well enough, they just may need to be reintubated and see if we can wean them off some more slowly. So, last one is pulmonary edema or pulmonary embolism. One of those things that we may see around here. Next. What happens is when you have a pulmonary embolus, the pulmonary arteries and veins end up with a big clot in them, and therefore you don't get any exchange from the oxygen from the blood to the lungs. So that's what that means by VQ, ventilation perfusion mismatch. There are different types of pulmonary embolism. It could just be blood. Sometimes it can be air. If you open up any of those ortho cases that we do, where they open up the bone, that bone can actually suck in oxygen and get that into your venous or arterial system and cause an embolus. It could be a fat embolus. Those are usually from long bones if we're doing anything there with hips or anything like that. Humerus could cause fat embolus, and amniotic fluid embolus. It's usually OB type stuff, but all those can cause a very nasty and severe problem. What you'll see, usually the patient will have some sort of, a lot of times they'll complain of, I feel like something bad's going to happen. They have a sensation. They will tell you, I feel like I'm going to die. Then all of a sudden they start developing chest pains, your oxygen saturation drops, your end-tidal CO2 drops if you're monitoring that. They'll be short of breath. They may have a cough. Sometimes they will be even coughing up a little bit of blood. But like I say, usually that feel of impending doom is kind of one of those first things that they tell you. And those of you guys been around nursing long enough, when a patient says they're going to die, believe them and start preparing for things to go bad. So, treatment, supplemental O2, their blood pressure is going to drop because they're not going to get that return to their heart. So they're going to need some blood pressure support, get them on Neo or something. Emotional support, because this is very scary for them, that feel of impending doom for them and their family, because this is going to be something severe, and then prepared for transfer out of here, whether they need to go next door or whether they need to go to Salina or Topeka to Stormont. Something's going to need to happen because definitive treatment is usually fibrinolysis, where they give TPA, drip, or sometimes they put a central line in, and they'll drip that right on top of the clot. May do a surgical embolectomy, actually go in and open up the chest and pull out those clots like you saw in that very first slide, or a minimally invasive embolectomy where they go to the cath lab and have it taken care of, or kind of the definitive treatments to that. All right, kind of quick, I probably burned through that. Well, 35 minutes is all. What questions do you guys have for me?
Okay, I just have a quick, the gentleman with the tongue, could he speak?
He's really garbled, but he can talk.
He could.
Yeah.
So that's not a tumor.
No, that's an AV malformation. So we ended up going in, and I nasally intubated him, and we ended up, they had to open up his neck to clamp off the, I think it was the internal carotid. They had to clamp off, and once they did that, the tongue just shrunk down because like I said, it's an AV malformation. So the arterial venous side of that, his tongue were all messed up. So we've been feeding that tongue with blood. Let's see if I can here.
Did he eat?
He could eat. I mean, he's Ethiopian. He was skinny, but it's.
What if he had, what if he'd injured that tongue? Would it lift it?
Good. You cut that thing, you're gonna bleed a
I was
lot.
gonna say, like,
That's
you
why.
bite your tongue?
Yeah.
They had some
How
issues. I mean, it was.
do that?
Yeah. Let's see. I got a picture of what we cut off here. It looks like a beef tongue that we cut off.
I'm not sure I want to see it.
That's what we cut off.
Lordy, have mercy.
Yeah. That's how
Oh,
much we cut
yeah.
off.
Yeah, it does.
I mean, his tongue looked pretty good.
Did you see it?
Do you want to see
Put it
it?
up.
His the floor of his mouth had some. He had the same thing, some of it. So I mean, he's got some issues there yet. But as far as this guy's a third-year law student, so now he's going to be able to practice. So this is the tongue.
What's the
That's
chances of
done.
reoccurrent?
It should be all right because they get rid of that,
They
that
fix
malformation.
that's okay.
So they finish picture. So.
That makes my tongue like,
Can
makes
you
my
just-
mouth hurt.
How he's gonna feel, I don't know how painful that is, but just everything that impacts.
Yeah.
From communication to.
Yeah, well, just to be able to swallow. That was one of the huge things they had to talk about during the surgery. That they're talking about, his speech, being able to move your tongue to speak, and also be able to move your tongue to get food to the back of your mouth.
Yeah.
How do you eat? Because
He had to be on a soft diet.
I know, like, he opened
Well,
it.
if you look at the very beginning of it, one of the things that happened at the end of that case, they're getting done. They're like the guys were like dislocated his jaw. And they kind of messed with it for a little bit, and I went back and looked at that picture, that video that I showed you. I'm like, no, guys, look, he's not closed here. So he'd been like that for so long, his jaw had actually remodeled, and he was not able to close his mouth. So,
To accommodate all that.
he'd been open so long to accommodate all that tongue in his mouth. So,
Because even that though,
So they'll
I'm
have
still
to do a
surprised
surgical
his
correction of
tongue
that,
wasn't out,
because
like,
now
hanging out.
I
it's
don't know
permanently
if
like
they're
that?
probably not going to do a surgery to correct that. I mean, that's a kind of a nice to have surgery, not a
Okay, not
need to
a
have
need,
surgery, and that access to something like that there is.
Yeah.
Yeah. But, yeah, so I actually had to have somebody hold that guy's tongue out while he intubated him, and we just kind of sedated him a little bit, and they held that tongue out to here while they're, and kind of held it out of my way.
Pictures of the girl after she's dead? Because that was
I got tons of pictures.
And how fast did that grow? I mean, was that just like?
Her face or the tongue?
The tumor on her
Tumor?
nose.
She was 10. I'm not sure when it started, but it's always been going for
And
quite
did
a while.
she have airway, would she have airway, did she breathe through her mouth? Is that what happened?
Yeah.
I mean, you would
yeah.
think that she
So, I
would.
mean, there's another picture of her. I mean, we got quite a few pictures of her. But,
Did you see crazier stuff in Africa or in Haiti? Or it's about the same?
I'd say it's about the same. We're gonna go do more here because Terry was with us, and we had we're in a 500-bed hospital, so we had more. They had an ICU and everything.
Mhm.
So this is halfway through.
Oh, yeah. She needs facial reconstruction.
Oh.
But you can see her nasal pharynx. I mean, this is all that's on her oral airway back down there. So that's halfway through.
Do you ever get to follow up with these people?
We get a little follow up on this girl, unfortunately. So this is her done.
That's what Eric said.
What a difference.
Maybe, I
Yeah, that's
don't
right.
know.
some swelling there too, just from the surgery.
But they're having some troubles with this area. Well, so it'd be right here. That the blood flow isn't good enough, so it's kind of breaking down here. Terry talked about going back in July and helping. She obviously needs some reconstruction, but in July I'm doing some reconstruction on her, so hopefully that'll happen. For her, she needs to have chemo and radiation. Like I said, it's a chondrosarcoma, so it's cancer. That's in her face, but yeah, so. Anyway, the big thyroid that you saw up there, one of those first pictures you saw, that's a Haiti thyroid. I mean, that's not unusual. I mean, you were there. It's not unusual to see those types of thyroids in Haiti.
That seems to be like a
They're
pretty common thing.
Oh,
Like
yeah.
that, all the
Isn't it
pictures I've ever
the-
seen from you in Haiti.
Lack of iodine.
Yeah.
Yeah, they don't have iodine or salt or anything else, so their thyroid goes out of control. But like I said, you guys know you are more than welcome to come back to the OR and hang out and put oral airways in nasal airways or do whatever. We can
Okay.
help you learn how to manage airways
That'd be
with
cool.
us. So we're all nursing us this year, so we've all been into nursing and know what it's like to start out. So you're welcome to come back. Or some of the guys are grumpy and old, but they'll still do it.
About half.
Huh? Half? Where am I at? What is that half? Wait a minute here. I'm kind of getting.
Teetering.
Yeah, sorry.
You kind of go back and forth.
Uh-huh.
Thank you.
All
Thanks,
right,
Chris.
thanks, guys.
The guy with the tongue, could he
Huh?
taste after that?
But yeah, he should be able to. I don't think they took any of the nerves or anything, so that he should be able to still taste and
Thank you,
everything. It may
guys.
be a little bit different, the scarring.